screen. And it looks awful if I try it.
I think we still have some people logging in, so we'll get started in about 30 seconds. It looks like we've kind of leveled off on people logging in. So I'm Elizabeth Krupinski from the Southwest Telehealth Resource Center. And welcome today to the National Consortium of Telehealth Resource Centers webinar series. Next slide. Hey, as everyone knows, hopefully, the Telehealth Resource Centers, there's 14 of us. We are a nationwide group that covers the United States in terms of the services that we provide in the regions that we cover. As there's 12 of us that do that, and there are 2 that cover 2 specific topics, technology and policy. We are here to help everyone with their telemedicine issues, questions, and everything that we could possibly help you with. Next slide. So some tips and hints for today's webinar.
Sorry.
Can you go to the next slide?
Fine. I'm not sure why it's not advancing now.
There you go. So please keep your phone and or your computer microphone has been muted. Not that we don't want to hear from you, but we don't want all the rustling in the background. There's going to be time at the end reserved for question and answer, plus we can some of the chat as well. Afterwards, there's a survey that we would love for you to fill out to tell us how we're doing. Please note that this webinar is being recorded, and afterwards it will be posted to the NCTRC YouTube channel that you can see there. Next slide. So it is my pleasure today to introduce to you 2 folks associated with the Arizona Telemedicine Program in the Southwest Telehealth Resource Center. The first is Kimberly Shea. She's a RN, PhD, CHPN. She's a clinical associate professor at the University of Arizona College of Nursing, and she's also an assistant professor of practice at the Department of Biomedical Informatics. She's done a lot of great work and has been able to get funding over the years, especially in the area of home-based telehealth for the past 16 years, which is really great. She has a lot of clinical experience and certification in home case management and palliative nursing, which is her area of expertise. Her research studies have looked at a lot of different things, and we're going to hear some very interesting things about that, but in general about the relationship building when technology is moderating interactions with patients and caregivers and nurses, patient integration of telemonitoring data into lifestyle choices, usability of iPad technology for symptom management, and the one she's working on now are best practices using the comprehensive patient assessment for telepath in-home framework, which she developed, and it's really quite fascinating. She's presented locally, nationally, and internationally on telehealth in general and telepalliative care specifically, as well as more general nursing things outside of the telehealth arena. She serves as Associate Director of Telenursing for the Arizona Telemedicine Program. She's going to be accompanied by Victoria Towers, MS, FN, BBC. She is currently a dual doctorate student at the University of Arizona. She's a board certified family nurse practitioner and has experience as a registered nurse in the neonatal intensive care unit as well as with telehealth. Her clinical training is in rural and international health, which is a great segue into telemedicine. while working with both pediatric and adult population. She's on a number of state and national nursing organizations and has publications and presentations in primary care and telehealth. So without further ado, I'm going to turn it over to Kim, and she's going to talk to us about novice to expert comprehensive patient assessment using telehealth in the home.
Thank you, Elizabeth. That was a wonderful introduction. So today, as Elizabeth stated, we're going to talk about the novice to expert transition and how that affects telehealth, and primarily for home assessments, which we all are much engaging in these days. At the end of this presentation, you should be able to recognize the importance of using that framework of novice to expert. You should be able to consider domains that we'll present to you on the comprehensive patient assessment telehealth in the home framework. And we are going to discuss some of the research we've done, and Victoria will discuss the themes from preliminary results of the ongoing CPATH study. So to just set the stage, this is not news to any of us on this call that telehealth has leaped forward and in the last few months as a result of our public health emergency, which is our COVID-19 pandemic. During this time, since March, COVID telehealth use has increased in the claim lines by 8,336%. That's, people have questioned that, and that's true, and that's in the year from April to April 2020. We've increased from 1,600 visits to 250,000 visits per month, and we have changes in Medicare reimbursement, which we've been working so hard to get. And telehealth has become reimbursable in a patient's home, which is an originating site now, or if you live less than 100 miles from a clinic. And this is something that has been a great dramatic change as a result of the PHE. Patients are now seeking out their providers based on whether they provide telehealth opportunities, and will visit with them through telehealth. That was never a criteria before. Our HIPAA penalties have been temporarily waived so we can get to people using various forms of video conferencing. We found out in the US Senate report that greater than 70% of primary providers are providing telehealth encounters. And the change has emphasized, is emphasized from primarily behavioral health, which we've all known that telepsych has moved forward rapidly in the past because of its nature and the use of video conferencing, to now other diagnoses are primary for telehealth visits. Telehealth, telephone and video conferencing are now going to be able to be reimbursed at a level comparable to in-person visits. And this one I find very interesting, that there's a waived need for in-person visits before an electronic prescription of a controlled substance. This is previously called the Ryan-Haight Act, and this act said that you need to see somebody in person before you could prescribe something such as a controlled substance. And that has been waived during this PHE time. The PHE continues to be updated every 90 days. And as long as that continues, and we've done a webinar on that, we will continue under these current ways of reimbursement and enabling telehealth. Just to put us all on the same baseline, telehealth is defined simply as delivery of healthcare services over a distance by using telecommunication technology. There are three primary types. I'm speaking to the choir today. So one of the things I want you all to know is that what this presentation is primarily about and is about video conferencing. Some of the take-home messages you can apply to other types of telehealth. However, think about the video conferencing because that is what has grown so much in our delivery of healthcare. So telehealth is here to stay. Various meetings that I attend, you know, they use different sayings to describe the fact it's there and it's going to be hard to go backward. This was clear in the U.S. Senate Committee on Health, Education, Labor, and Pensions meeting where we had witnesses for telehealth attend and say that, you know, there's been so much advancement. And if you get the chance to look that up, that Senate hearing, it was fascinating. 20 years of work and effort, and many of you can attest to that, have been realized in the last few months. And now we have this opportunity to practice what we preached. And we always talked about as providers, providing patient-centered care. Well, now we can do it because we are actually visiting people where they live, and we can see who they are, what they're about, and really understand a little bit more about them to provide more personalized care. But right now we are all novices. Yes, some of you may be have delivering telehealth in some form for a while, but not in the volume that you're doing it now, and not with the risks based on that volume that you're doing it now. So based on the fact that we are all novices at this point, I really find this understanding of how we advance in our skill of telehealth to be critical, and understanding what does a novice need versus what does an expert need as they advance, and the various items between there. So the novice really is where we're at now. We need to see that we can succeed, we can deliver telehealth by using video conferencing, various technologies, and that we can get it done. There's almost a hasty mindset of let's show that we can get it done. But as we move forward, we're going to move into this knowledge, you know, what knowledge and information do we need? How can we troubleshoot using the technology that we're using? And as we get more competent, you know, how do we solve the problems that we're really addressing through our home-based assessments? And, you know, but we're still having a little trouble, pinpointing which details do we focus on when we talk to somebody in their home? What are we doing with this technology and this interface we have between the patient and us, which is the provider remotely? And then as we get closer to expert, we start to look at the bigger picture. We get frustrated by oversimplification of, oh, let's just talk to somebody on a video. And then as we get to expert, we become a source of information to others and very intuitive about what is it we're looking at. And that's what we're going to talk about today. So what are some of the risks associated with static video conferencing? Well, on the left, you can see that the human eye, you know, sees a lot of peripheral vision, right? There's the central focus and there's the peripheral vision. Well, telehealth with that camera does provide a very narrow focus. We don't get that peripheral vision. Here's a guy that we see in our telehealth visit. You know, maybe he's sitting at a desk. We don't even get to see that he has muscles and has good color to his skin, etc. But if you were to move the camera out of that narrow focus, you would see that guy's a slob. He basically needs to put things away. Now, maybe if you moved it even further into his kitchen, you would find that he's got food sitting around. So, you know, the peripheral vision isn't there, but the narrow focus of the camera is. So we need to really look at intentional viewing. We need to think about before we do the telehealth visit, what are we going to look at? What are the problems that may be associated with this individual that we are assessing? Novice to expert talks about, and those theories that I cited there, talk about the need of guides for advancing from novice to expert. Guides are very needed for the novice because the novice needs to have a prescripted way of doing things. As you move to expert, you don't necessarily need that guide, but having used the guide is what enables you to have it integrated in your head. And I'm sure many of you that are providers can think of your skill acquisitions as from when you started as a student to when now you are an expert, and how those things you learned in school were so basic and you had all these rules and regulations, and now perhaps they've moved on to being more intuitive. And you can look at this progression of how the guide fits within that trajectory from novice to expert. Right now, considering that we are all somewhere around here, we're going to talk about what those intentional steps for a telehealth visit are, and what we have done some research on to try to figure out how do we determine those intentional steps? How do we make this more of an organized visit that we can collect, be efficient at, and get whatever data we need to make accurate decisions? Some other research I've done just to set the stage is the importance of small talk in the beginning, comforting, creating a relationship, and then a shared understanding. When we have the visit, the remote video conferencing visit, I found in this study that I did about many years ago, it seems like, that if you just started into a visit remotely with people, they really, because of the lack of context of the person visiting, they're used to going into a clinic based on what their needs are, and the doctor is in that room with them. You really need to create a shared understanding. What I'm going to do in this visit, why I'm doing the visit and the video visit, right? And why I'm looking around, and what am I going to do with the information that I find? That is, it seems like these things might take from your time when you start your visit, but they're critical for creating a baseline that will get the most from your telehealth visit. Then I'd like to propose that we then move around the house and get some information that can help us, but we need to get consent from the patient. You wouldn't walk into someone's home and start walking around looking at things. None of us that have been home health nurses, have been home health providers, would ever do that. You ask and you assume that, because the patient is in control, which creates a very different dynamic. And I think it's a wonderful dynamic when we visit homes. They are in control, but you can also, when discussing using the video or the phone to walk around and look at various things within the house, you can show the patient how much control they can have by switching the camera. And all of the video conferencing, Zoom is one of them, have on the mobile app a little button, just like you would for changing it from a selfie to a camera. And they can just select that and use that to show you what you're asking for, but they have some control and they can see what's in that camera viewfinder. And that, I find, is critical for them to, first of all, have some control, and secondly, for you to be able to see more accurately what you're asking to look at. And then we are going to inform them as part of the why I'm looking around and what I'm going to look at, these domains. And then we're going to talk about these domains as part of our presentation today, because they're the basis for our research and where we are at with the current research. And what we found are 4 domains that are really critical to home health providers, and that is the environment, the equipment that's in the home, medications that are in the home, and patient characteristics. Our research found that also what is critical that we didn't think about at first were caregiver characteristics, and those are important to observe as well. So how did we develop those domains? Well, the original study was a quantitative content validity study. We wanted to find out if the content of the instrument we wanted to use to guide us to look around the house had the right things in it. So we had 7 experts from a Southwestern home health and hospice agency. They go to the home all the time. This is what they do. This is what they're experts at. And they had to have greater than 3 years of experience. And we asked them to look at an item list that was 20 items, just to start them out with on various things, and for them to add additional items if they felt that they weren't, what they thought was important wasn't on the item, but then on the list, but then to rank them. And this is part of the quantitative content validity that I'll show you my reference to that in the analysis. But they have to rank them from strongly agree to strongly disagree. And it's a 4-point scale rating because we don't want ambivalence. We want them to agree or disagree, and they can have some variation in that for our interest, but to really determine if these things should be on the list. Their instructions were to pretend or visualize, which they do all the time, that you are entering a patient's home for a nursing visit. What would you look at in order to do an assessment? Because as we know, you don't necessarily just walk in and go right to those things. So they may not be in an order. They may be, and we're finding out that very much within our research, that they are scattered and kind of looked at peripherally and gathered information. But now you have to define, what would you look at in order to do an assessment, and rate how strongly you agree on the need for each item that we had in that protocol, that list, and then add additional items. Well, this was a study that was done quite a while ago. It was actually in 2017, which maybe isn't too long ago, but it seems that way. And this is based on, the analysis is based on this determination of and quantification of content validity. Lynn did a statistical analysis of when you have experts, how many have to agree for it to be significant, a significant amount of agreement. And what you're seeing here is with 7 experts, which is what we had, you have to have a 0.86, which is 6 items agreed on or more. I'm sorry, 6 experts agree on that item or more. So either 6 or 7 experts have to agree that this is an important item. And that gives you a significance value of less than 0.05. So these were our results. Our results were really interesting. And this is the way we came up with what we call now the CPATH, the Comprehensive Patient Assessment for Telehealth in the Home. And these were items because, now consider that these were nurses and providers that were home hospice nurses. So that is a consideration, because one of the things that was very critical and enables us to move it from palliative into patient assessment is the variation in depending on, what are you agreeing on? What are you looking at? So many hospice patients, all of them have respiratory issues, heart failure, compromise, that's the majority. So it would make sense that within these stated that these were all areas that they needed to look at. And then what we did was we grouped them to create the domains within these different domain areas. Safety was also an issue, and that fell under environmental quality, everybody agreed on safety, and it was the #1 ranked item. But interestingly, so was guiding patients through administration and how they take their medications. That was also critical and #1 ranked. The other thing was nonverbal gestures. What does the patient look like? Are they grimacing? Do they look tired? All of those things that you see when you visualize a patient. Then second ranking was breathing, and then the types and the dosages of medications. And as you can see, the standard deviation was lower depending on the higher ranking. And that makes sense because we're talking about agreement, right? And then it goes from there as to what they felt was important. So this is how we came up with the CPATH. The CPATH contains, and we'll look at it a little more, the physical characteristics, the equipment, the medications available, and the environmental quality. We tried a little with what do you look at first? And some of the nurses said, well, I go in and I look at the environment first, you know, because I walk in the door. But then what happens quickly is you go into patient characteristics, you know, so you don't, maybe you don't specifically see the items in the environment that you're looking for. So they don't necessarily have an order. But also, here is what they added, that caregivers require assessment and visualization. So to turn the camera on the caregiver when you talk to them. These things were, as I just stated, the 0 standard deviation or the highest ranked were items that there was no question that was strongly agreed upon by the experts. But then again, depending on the diagnosis of the patient, the purpose of the visit, and then the context of the home environment. Was this a nursing home? Was this an assisted living? Or was this a residence? Changed the variation, and not necessarily the strength, but it changed how they ranked them. Okay, so what do you do before you go into a video visit? Well, it really looked at two areas, two types. What do you do for ergonomics, for people being able to use the technology? We call it human factors sometimes, so that it's a good visit. And what do you do to create an efficient visit? Because one of the things that we found from the CPATH is there was this variation in what was important in the assessment, but it was based on what was the purpose of the visit and what was the diagnosis. So we needed to look at what do you need to prepare so that you can be efficient. The ergonomics wouldn't change, but what is it we need to do? And these ergonomic items are things that we found, you know, one click, I just text them on their phone, the link to the Zoom. Not all the other information, not all the other things. As long as they have that Zoom app and click on that link that comes in their text, they can visit with me. It's very much simpler. And there's other softwares coming out now that realize that, you know, putting in codes and all these other things make it difficult. But you also have to consider the HIPAA concerns. That patients are familiar with their software. Patients know their cell phones. They know how to use them. In most cases, we've had, and Victoria might speak to this, but we had a fellow the other day who never even owned a cell phone, but he was able to go through a visit and did an excellent job. Once he got familiar with using it and clicking around on that phone and using different apps and, you know, he doesn't still know how to put contacts in, but we're working on that. So prepare your technology. You're talking on Zoom all the time now. So you know if your audio is hooked up, you know if your microphone, you just had a meeting before that. So this kind of takes care of itself. And then your background, we're all working on our fun virtual backgrounds and things like that. But also position your camera. I find this quite annoying when I have people, the camera's on the side of them and they're talking to the screen where they see a person. So they're not looking at the patient or the person. So now for efficiency. This is where our CPATH comes in and the domains can come in. You know what the diagnosis is, you know what the risks for the person based on their comorbidities, whether they have care in the home, whether they don't, what are the safety concerns. You need, these things will help you if you quickly think them over. We're not talking about a half-hour preparation here. We're just thinking about if you have a list there and you think through it, you can come up with some things that you find are important to have the patient show you in the home. And prepare for the flow. If you're going to go over something you want to educate, have it on your screen so you can share it. Also have it available, labs to review, things like that you're looking at already in the electronic health record. Pull them up and share your screen so that you can actually have a visual to quickly go over things. It makes for a very efficient visit. And then review these CPATH domains that we just talked about and we're going to look at to see what things you would look at within those domains that would be important based on the risk review, based on what you know about this patient and what you want to make sure that that you look at in the home. This is, just a guide that we've used to look at, that we put into a guide format based on a COPD patient, based on somebody that's at home and that is bedbound. This is an end-stage COPD patient. So that's where bedding and, interestingly enough, skin color came under the patient characteristics. We put that under there, but not bed sores and things like that. It was turgor and skin integrity, I guess, could be bed sores. But just thinking about these 4 domains, the environment, the equipment, the medication, and the characteristics for a COPD patient, I can think of things I want to make sure I ask the patient to show me in the home. We had a meeting the other day where the nurse came into the video visit. She felt she knew the patient. She had visited with this patient before. If she had walked into that home, she would have seen that the patient's feet were edematous. She would have noticed that right off the bat. She didn't see it in the video visit, but because she thought about what the characteristics might be for a COPD patient that you need to look at, that is something that she could then see on the video visit and had that on a list of things to do during the visit. So that's all of my part, and we're going to go over to the current CPATH study, and I'm going to stop sharing my screen and let Victoria tell you about our current study. We talked about how we got to the CPATH. Now we're testing it.
All right, does that see okay? Hopefully on there. Okay, so now I'll be going over a little bit about our current findings that we have with the CPATH study that is ongoing. So these are preliminary, just to preface all of these results and reporting, but we are very encouraged by it. So we'll just give you a bit about what we've been doing. So we took all that work that Dr. Shea has just described and we applied it to a study design where we wanted to actually apply it to visits with patients. So we used a mixed methods approach. We're looking at both the qualitative and the quantitative findings that we could both record and also build off of from the different interventions and interviews we were completing with these patients. So inclusion criteria, the patients we were recruiting had to be greater than 60 years old. We are specifically looking at the hospice or seriously ill population. So for that reason, they had to have requiring ongoing symptom management for at least one of these 4 symptoms. They also had to be able to use email and a smartphone with a Wi-Fi connection at least weekly, because it was how we were completing this intervention. So that was a requirement, and fortunately we had no problem with that. Most patients, like Dr. Shea was saying, our most recent participant had no experience, but was very engaged and was willing to learn. Exclusion criteria were pretty minimum. They just could not have cognitive impairment or immobility. We are looking around the home. That was the intention of this study. So we wanted them to be able to move around and show us what their home was like. And like I said, our recruitment was from the specific patient population in an Arizona-based organization. So what we did with this study, once we recruited patients, which we had an incredible sample pool to pull from, and also a great amount of interest, seeing as hospice patients, the majority of the population we were looking at were already homebound. Doing a telehealth visit in the home was a great opportunity for them. So we had great interest from that. And we had the consent form signed by both the participant and the caregiver, and that was done electronically. And then we initially set up the intervention appointment. So we had 2 appointments, which I just like to clearly delineate because they were separate. But our first appointment is our intervention appointment. And that was where we had a team on the call, which was the patient. And then if they did have a caregiver, they were also on the call. The hospice nurse practitioner, a social worker, and then a member of our research team. And during that actual intervention appointment, it was completed via Zoom. We were going through the CPATH model. So we had the hospice nurse practitioner conduct the visit like she would in person. However, she was using the model that we were proposing to specifically and intentionally look at specific things in the home during this visit. So those typically lasted between 30 to 60 minutes, depending upon what we were looking at and how complex the patient might be. And then following that intervention appointment, we sent them an electronic survey, and we used the data system of REDCap for them to complete a series of questions about their experience with that intervention appointment. In this survey, we looked at both quantitative and qualitative findings. So it was really important for the patient to be able to express their opinion, but we also wanted the opportunity for them to tell us what they thought in their own words. So following their completing of that survey, we then scheduled a follow-up interview appointment. And this was coordinated just between the patient and then a member of our research team. And that interview appointment really was just an opportunity for the patient to tell us in their own words their experience with it, what they thought, and kind of just gives them an opportunity to share a bit more than just filling out a survey. And then the participants were compensated for their participation after that. So our preliminary quantitative findings, like I said, this is still ongoing, and we have future patients scheduled, but to date, we have 6 fully completed interventions and interviews, and they have been absolutely wonderful, and all of the participants have expressed great interest in being a part of this study, so we've been really fortunate. And looking at the biggest thing that we want to know is, in these domains that we've identified using the CPATH model, how much of that time is spent where? So part of the call during that intervention, a member of our research team is tracking how much time we are spending on each of these domains. And so interestingly enough, our greatest domain, and it speaks to the fact that we really want this care to be patient-centered, our greatest time spent is with the patient. And these numbers here in the parentheses are in minutes. So during these calls, how many minutes we're spending on which domain. And so the greatest here is with the patient. Like Dr. Shea said, it might be patient characteristics. So if we're doing a visual assessment, looking at specific aspects of the actual patient, that falls into this domain. It can also just be if the patient is talking with us, or if they point out something specific that may lead us to another domain, but it's all pertaining to characteristics of that specific patient. And then significantly, the next lowest point is the environment. But that is reassuring to us, because the point of the study is also we want to intentionally view aspects of these patients' environment and where they are in the home. So we're reassured that the second greatest domain here is that we are looking at the patient's environment when we are on these calls. And then the other side of this quantitative data that we're looking at is the information we've gathered from REDCap. So like I said, the survey that's sent out is then completed by the patient and the caregiver. And we're looking at a couple different areas specifically because we want to know how well this type of intervention is being embraced, how easily it is for them to use it, and if they're getting something out of it. We want this to be a productive visit. We don't want it to just be a formality. So we really want them to have a benefit from participating here. So these different areas are really the items that we're looking at within that survey, and the vast majority of patients are finding that it's useful. The technology, given today's day and age, they are being a little bit more adaptive to embracing this type of technology. So we have been a little bit fortunate with that. We're having a little bit uptick in people willing to use it. And then probably the most important part of this as well is that degree of feeling cared for. So we want this visit to be patient-centered, we want it to be beneficial, and we don't want it to be just a remote visit of just seeing someone on the screen. We really want them to feel like they're involved, that they're engaged, and that this visit is intentionally trying to be a benefit for them. And I just wanted to highlight here, all of these items are evaluated on a 5-point Likert scale. And all the participants thus far have reported feeling either very satisfied or mostly satisfied with the services that they're receiving through the study. So that's very reassuring for us, and we hope we can continue with that. But it's showing that the patients are enjoying our intervention. So here's a bit of our qualitative results as well. So like I said, after we do the intervention appointment, we do a follow-up interview appointment, again over Zoom. And it's just that opportunity for the patient to express in their own words how they felt about the intervention of doing a home visit. We have it set up in an open-ended conversational interview style. We do have a couple questions to ask, but most of these patients already have an idea of what they would like to talk about. Typically, there are things that they really liked about the visit, or they give us suggestions for improvement. So it's been really beneficial to hear their perspectives because we have had some similarities, but also some really unique participants that have different backgrounds, so they're giving us suggestions based upon that. In our analysis of these initial qualitative results, we're using an inductive approach to qualitative description. We did a content analysis with independent coding, and within all of those independent codings that we've done, we've had at least 80% similarities, so we're really reassured in that fact, as well as that we're finding a fairly amount of significant and quick data saturation because these patients are reporting similar things, what they liked, what they didn't like, and suggestions for improvement. So the main themes that we've identified so far, the first one pertains to this usefulness of the telehealth. And a lot of these patients are placing that on a situational continuum. So what that might mean is for hospice patients, they typically know their providers very well. So being able to see a telehealth provider every other visit instead of having to go into the clinic is very beneficial for them. And they really appreciate that opportunity. It reduces their need for travel. It's less stressful and things like that. So the applicability of these telehealth visits we've seen as being highly applicable. Some people would prefer to do it for every single visit. And some people are saying, we don't really know yet, but we still prefer being seen in person. So it's being placed on a continuum that we would like to say is very much based on the situation of the patient. And so far we've gotten great feedback about that, but that's kind of where we're seeing this fall. The second thing we've identified is privacy and confidentiality. So like Dr. Shea had mentioned, all of our findings and everything is based upon HIPAA laws and regulations, and we want it to be simple for the patient. So we don't want to overcomplicate anything by, having something specific come over that. But all the patients feel that it's very private, that they're in their home. We ask for the opportunity to look around. So we are obtaining that consent. And they don't feel any types of concerns for privacy or confidentiality. A couple of our patients have even said, they prefer it from being in the clinic, because sometimes when you're walking into a clinic, who knows what is hearing who and walking through halls and such. So they feel very safe and willing to share while they're in their home on a telehealth visit. The technological support is also a huge component of this. Obviously, we are relying on technology to deliver care, so we want it to be successful as well as efficient. And most of the patients have given us feedback that they really appreciate that we're either partnering with their caregiver to make sure that this video and these appointments are smoothly coordinated, so they're not necessarily having to worry about setting up these visits. The caregiver is involved and willing to help us with that. But as well as the fact that we are willing to involve, we're happy to help them set things up or call them, you know, the day before to make sure everything's ready to go. We're not just saying be on this call at this time. And then the last part here is communication and relationship building opportunities. So such a significant part of telehealth is the engagement that you're simply doing. Some of these patients, like I said, are hospice and they're homebound, so they may not be leaving their home, you know, if at all. So this opportunity to speak with a caregiver and speak with a provider is an opportunity for engagement that they've really appreciated, and also that we're taking this time to, you know, even if it's only a half-hour appointment, they might really appreciate that. That might be, you know, one of the exciting parts of their week. So we are just building upon that and making sure it's a positive experience overall. So based upon these preliminary findings and what we're seeing, we've kind of been able to converge these qualitative and quantitative findings as well as these opportunities for our research moving forward. So the first part is what we're seeing is this really is an opportunity to not only address physical and emotional needs, but also their future health needs. So when we're talking with these patients, you know, even if we're just looking around their home, we may see something that we would not be able to identify if they were in a clinic. So being able to be in their home and intentionally looking to view their bathroom or look at their kitchen counter where they store their medications, it gives us an opportunity to truly build upon that and expand upon our findings and hopefully expand upon our care. With that, it's also improved health management. So when we're talking with patients, we find a lot of the time they share, you know, details that may not come up because they're sitting in their home and they're looking around and they think of something that they may forget if they were in a clinic. So these opportunities then to discuss those types of things on a telehealth visit are very easy to integrate into that simple conversation. And then if we don't have a direct answer, we can say we'll follow up with that, but at least that communication was shared. So just this opportunity to integrate not only the designated care that we're doing and the comprehensive care that we're trying to deliver by involving the whole environment and looking at everything we can, we're doing that with the technology that we have. And finally, like I had mentioned, this engagement and the communication without distraction and in their privacy of the home truly has been something that has been consistently reported by patients that they are truly enjoying. They really appreciate that opportunity, especially in this hospice population. They may not have that level of engagement that they're used to in their previous years, so they really are enjoying this opportunity overall. And just one thing that I'd like to point out so far, this is one of our questions on our REDCap survey, is if the smartphone with video is available for regular use in palliative home care, would you recommend it to a friend? And so far we have 100% yes. So that's very reassuring as well. So what we'd like to do, like I said, this is an ongoing study, so we will be continuing to enroll participants, continuing to apply the CPATH model, and where we kind of see this going with all of this is we'd love to apply it to other populations. The comprehensive patient title was intentional because we really want this to be able to apply to other patients regardless of what their medical needs may be, because the simple task of intentionally viewing part of those domains can be easily modified by the provider based upon the patient's situation. But it just makes the provider think, you know, I need to be looking at the medications. I need to be looking at what equipment they have in their home and what that might be can change. But that's the important aspect of this. And to apply this to the novice to expert framework is we hope that once people can begin to use the CPATH regularly, this will become second nature. So then you may do this on a call without needing to follow the direct steps, and it's just a natural transition into how you conduct visits. So a future initiative as well is the preliminary assessment for new patients prior to their standard clinic appointments has been requested to be completed using this model. So some patients are saying, can we do a CPATH-driven home visit before we see our provider in person? So they have an idea of what who we are, where we come from, and maybe that may drive their care once they're actually seen in person. So that was a very interesting recommendation we received from a couple of our patients. And then finally, this educational opportunity, not just for telehealth providers, but for everyone to really be intentional, even if you're seeing a patient in person, be sure you're asking about, their home environment, what equipment they're using, and things like that. So it's just a reinforcement of hopefully a comprehensive patient-centered care approach. So in conclusion, as Dr. Shea was saying, telehealth and given today's current pandemic, it has increased immensely, and video conferencing reimbursement limits have been reduced due to the current situation or matched to other findings. It just depends. Be sure though to, even though that may be a national consensus, just to check with your state legislature as well. The narrow camera lens limits what can be seen and reduces these cues for assessment, and this is why we truly encourage that intentional viewing and following the CPATH model, because it allows us to view so much more than just getting the selfie view of a patient on a video call. And applying this to our novice to expert framework, as we said, most telehealth providers are novices, even if they've been doing it for 10 years now. Things are changing, the way people live are changing, and we just want to be sure that this model encourages the adaptation of that so that we can continue to deliver patient-centered care. This was developed from experts in home-based care, so we truly know that the findings that we're intentionally looking to view are important, and that may grow as we apply this to other populations. Certainly that can adapt and change, but like we said, it's ongoing. We're encouraged by our results that we found so far, and overall we just really hope that this gives an idea that when you're doing a telehealth visit, really be intentional about what you're looking at, because you never know. The patient may show you something in their kitchen, and that may lead to a whole discussion about their family history, and you may learn something that you didn't know about the patient to drive their further care. I think that's all from me, and I don't know, Dr. Shea, if you had anything else?
Just to thank you. We've had students and other folks in the Arizona telemedicine program all helping us along the way and continue to help us. So just a shout out to all of those folks. And then I think that's it, the questions. Any
awesome
questions?
No, thank you very much, both of you. That was just a lot of really great information, and there's a lot of comments in the chat talking about great presentation, thank you, and so on. So we do have about 5 minutes for questions, and we actually have a lot of questions. And for those of you that have put them into the Q&A, if we don't get to answer them, we will be collating them, and hopefully we can get back to you afterwards with a list of the answers. So let me just try to get through as many of them as we can. So group education options, what exists for these types of services? Because they want to be compliant and billable after the PHE. So are there options, education options for all this?
Are you talking about telehealth in general or the CPATH?
I think specifically for the CPAP.
Okay. Yeah, no, we're trying to build a good database for this, as well as publish this and trial it, and would love to be able to, share or educate people on the use of it. But at this point, if you have a group or something and would like to have information, we certainly would be happy to present to you. So your group can use it, whoever you are working with, your organization. But at this point, no, this is strictly in the research development base. And interestingly enough, it started before the COVID world, well before. And yet now, timing is everything, I guess. And it really has gotten a lot of traction at this point. So anything you would like to reach out, you have our emails, you have the telemedicine emails, the ATP, and also the National Telehealth Resource Center. So please do.
Great. Can these tips also be applicable to community health workers?
Oh, yes. Go, Victoria, you're nodding, so you take that one.
Yes, please do. We're using this in the setting of telehealth, but it can be used in any in-person interaction with the patient. Really, we're just trying to encourage the intentionality of viewing a patient within a comprehensive setting. So, however you wish to apply that and translate that into your own practice, please do. And maybe record your findings and see if yours is similar to us. But yes, absolutely.
Yeah, and the reason I got so ecstatic is I have a student who's really interested in community health workers and the lack of guidance perhaps for them, yet they are so important in our community for taking care of either our elderly, and we're doing telehealth and adult care homes now. So there's just a lot of opportunity to grow and to give some substance to what we've just kind of been winging.
Great. Would the CPATH be for assessment of a new patient or a returning patient or both?
So we've gotten that feedback as well. We see it as being applicable to both. However, it is patient dependent. So and anytime you want to know the most comprehensive picture of your patient, sometimes when we do a visit with a patient that our nurse practitioner is very familiar with, you can kind of see the nuanced care that she already kind of knows a bit about how this patient manages their meds and whatnot. So it can easily be modified, but certainly applied to both types of patients.
Great. Where can we find the guide?
Well, the guide has been presented, and I do have the references on the slide deck. A official article has been submitted, and hopefully it will be published, and that will be available for you to look at. Elizabeth will certainly know if it's published, and also, email me and I'll tell you the journal, because if it's not accepted, I don't want to tell you a journal at this point.
Okay. Has it been used with any other populations, kids, mental health, etc.?
No, it's just been used with palliative care. And I think it was fortuitous for us to start with palliative care. And the reason I say this is that palliative care patients, I think, are a very good group. They've got many comorbidities. They've got many pieces of equipment. Home visits are critical for them. So it started before telehealth in the community. So those were the group that weren't getting out of their house, but yet, they weren't critically, they have a terminal or a serious illness, but it's not enough to keep them in bed all the time. They can get around. They're living their life still. They just are seeking palliative services for medication and symptom management. And it was a great opportunity that wasn't being really embraced too much till telehealth, but this was a great population to start with. So now we're saying, oh my goodness, with all this telehealth going on, this is a great guide, because we are all novices and we do need a guide, and that's, so please feel free to use it if you feel it would fit your population, and send us results.
Great. So I got time for one more question and then we have to close up. Victoria, when you mentioned independent coding, can you say a little bit more about what you meant by that?
Sure. So the interview that we completed as a follow-up interview, we had all of those transcripts transcribed. And then as independent reviewers, we had 3 researchers go through and code it for thematic coding. And what we did is we used those and we developed categories, and we really built upon it. And based upon what we all independently reported, we found about 80% congruence between what we were looking at. So, that gave us pretty good trustworthiness in the fact that we were looking at similar things based upon the patient responses. And so from that, we were reassured that what we were looking at was congruent, and we have pretty good data saturation based upon our feedback.
Right. Well, again, both of you, thanks very much. Unfortunately, we are out of time. For those of you who still had questions in the queue, thank you very much. Like I said, we will try to collate these and get the answers out there. Kim, if you could put your slides up again and show the final slides.
Absolutely.
Again, everybody, please remember there's a survey that you can follow up with after this that is very useful to us in terms of looking at content and presentations and future presentations. Again, this was a recorded webinar, and we will be posting it on the NCTRC YouTube website, and we at the Southwest Telehealth Resource Center are also going to get a copy of it, so we'll post it on our website as well. And as Kim is bringing up the rest of the slides, hopefully it's all just more thank yous and stuff to the other TRCs, to the NCTRC for helping us sponsor this and to get the information out there. Remember, we do this on a monthly basis.
That's the last slide that there is.
So again, this presentation has been part of the National Telehealth Resource Center's series. It occurs every third Thursday of the month. And the next one is going to be on September 17th. And it's multicultural patient engagement drives, improves outcomes. Again, those are the times listed there for you as far as this topic goes. Again, your opinion is very valuable to us. Please follow the link and fill out this brief survey. Thank you very much. Next slide.
That's it.
That's it.
There's only two.
Thank you so much for attending this webinar. Hope you got a lot out of it. And Kim and Victoria, thank you very much. It's an incredibly important topic, and you guys have done just amazing work. So thank you all, and thank to all of our attendees. Have a good rest of your day.
Thank you all.
Thank you.